So thank you very much. I'm going to ask the other speakers, Dr. Knight and Dr. Jones, to come up. And I think a couple questions have come through. As they're taking a seat, I'll throw out a couple thoughts that I had. So as I'd said earlier, it's actually quite reassuring that some of the very same issues that were discussed here are exactly what I've been experiencing back in the United States. As a clinician, and maybe people in the audience are already thinking about this, there are wonderful goals expressed here. I think one of the fears sometimes with things like patient-reported outcomes, which sound great, are that sometimes there's going to be giving more data to clinicians. And in this data-driven world, I think we're sometimes afraid. More data is not necessarily better data, even if it's patient-derived. And there's, I think, a challenge of how do we manage all that data? You know, there's limited time, there's limited energy to deal with some of this. So I think a lot of people are skeptical about where patient-reported outcomes fit in, quite frankly. I think something like rheumatoid arthritis is a wonderful place where it can have a role. I know that back in the United States, I have a number of physicians who are very afraid to communicate excessively with patients. When they say, check your blood pressure, at home for the next couple days, they have people who will send them pages and pages of blood pressure numbers, and some of that's helpful, but not always. So where's the fear over excessive data, I guess I would kind of throw out. What are your thoughts on that? Dr. Jones.
Right, so there's a few strands in that. I mean, one of the concerns I have about better technology for empowering patients to report their, symptoms and so on is that we may just be providing better care towards people who are already well served, and it's maybe not going to really fix the issues about the lack of reach to people who are not, who have unmet need or who are poorly served. That's part of my anxiety. But I mean, I can speak from my specialty in rheumatology. I know there's been a number of initiatives, such as we saw in the video, of people, reporting their joint counts, and that has been researched quite extensively. But talking to people who've used that over time, they say that actually they found it less useful over time because they've actually found that the actual joint count was not that relevant to clinical decision making. Because the issue is not so much whether you've got 4 or 8 swollen joints, it's whether you've got any swollen joints at all. So there is sometimes a little bit of a risk about, are we really measuring the right thing? And you do have to keep the focus on what's really clinically meaningful.
Yeah, adding on to that, as Dr. Knight, so in the medical home, a lot of the medical home construct that I'm aware of is communication, is good communication, it's remote communication. Some of that is sharing clinical data that we don't get in person. So how do we, as people are thinking about, do I want to become a medical home? How much do you want to invite a lot of extra data when in many cases we don't even know that some of those pieces of data are really necessarily helpful anyway?
Well, I guess in Australian general practice, we've had a paucity of data till now, so we're kind of excited to get any for a start. I think one of the great things about having a long-term relationship with someone is you start to understand them more, and they understand you. If you're truly patient-centered, some people love to get their own data and thrive on it and will handle it well. I can think of other patients of mine where their own data will just create intense amounts of anxiety, and learning how to manage that will be a major challenge. So, and there's many stages in between. So I think that's an opportunity for the longitudinal trusting relationship of primary care to adjust, actually, on a personal level. That's one reaction.
Deborah, how do we tell patients that we want their data, but then say not too much?
I think it gets back to forming that trust relationship with your patient, getting to know who they are, and then if you understand them, you're going to have a pretty fair idea if they're going to send you reams and reams of data rather than understanding what's important, what isn't, and what adds.
Yeah, I think one of the other aspects of the medical home is having the right people on the team so that all that data is not coming to the physician or the nurse practitioner, the clinician. There's somebody else who's kind of a little bit of a filter That's one of the challenges, I think, of constructing the right team. So although I think, as I said, the who's on that team varies depending upon the practice situation and the resources that you have, one of the things that I think about that we're struggling with in the United States is how do we incentivize? You mentioned, Dr. Jones, kind of incentives, and sometimes getting perverse incentives or the wrong incentives. And is paying for quality the right thing, or what else do we pay for? And so my question is, if we accept the premise that I think the data is quite compelling, that the patient-centered medical home as a construct has tremendous evidence in terms of where it's been done, in terms of saving money, driving better outcomes, I think giving better patient experience, all of those things that we know we need to try to achieve. So if we know that we need to get there, how do we incentivize the different people to do it? So the first question is, how do we incentivize practices to put those constructs in place? And in the States, there's a little bit of financial stuff behind it. I'm not certain, is that happening yet, or how do you envision that? I'll start with Dr. Knight.
There is a little bit in Australia. There's been something called the Practice Incentive Program, which is a move to a sort of pay for performance. I agree. I think there's real problems with pay for performance because you only get the things you incentivize. There's a real problem. I think pay for improvement is something that was mentioned, and I think maybe that is a better way to go. I know that the quality improvement framework in the UK, they ended up with quite a few perverse incentives where people were ticking boxes rather than paying attention to the patient's agenda. I know in Scotland they've actually moved away from the QOF to more of an approach to incentivise the intrinsic drives of the clinicians to do a good job. However, I guess having worked in an environment where there's almost no incentive, no capitation, no money for anything other than the constant throughput, what they sometimes call the hamster wheel approach to medicine, the constant fee for service, I think we need to turn up the dial of capitation a bit. We need to turn up the dial of pay for improvement a little bit in order to get at those sorts of outcomes. So I think we need a mixed model, actually. Yeah.
Dr. Jones, you want to comment? I'm going to get to some of these questions after
Sure.
this.
So I think what needs to happen is that you move away from paying for activity and widgets and paying for and commissioning for outcome, and that's easier said than done.
So in terms of outcomes, I think that our system in the United States, and I'm sure here and elsewhere, we know that 10 to 20% of the patients are 90% of the costs. So the first question that would come across was, how should we be constructing or using the medical home for the high-cost patients, the hospital frequent flyers? It's nice to talk about people having a primary care home, but what if they never go to the primary care doctor, the so-called medical home? Maybe they're neighbors and they have specialists, but the people who are truly the frequent flyers, who are a lot of the expense, how do we try to get our hands around that? Dr. Knight, I'll give you the first crack at that one.
Well, look, yeah, the whole frequent flyer thing is really interesting. There's this thing called the patient activation measure, the ability of a patient to actually manage themselves. There's people with similar levels of disease who manage themselves very well. Something about health literacy. We think these people probably need greater intervention, care coordination, and that's probably the answer. And there's a lot of interest in establishing care coordinators in general practice or in primary care somewhere, whether it's between general practice and the hospital and the community. I think that's probably an answer, and I think at the moment in Australia, certainly in New South Wales, a lot of these programs are being coordinated from the hospital. So actually identifying the frequent flyers and trying to do something in the hospital for the frequent flyers, which isn't really the answer. I think we need to do it in the community. Probably, and there are some programs being trialled to do something in between. So there's something called, for instance, in Western Sydney, a rapid access clinic. So if a GP identifies someone at risk of admission, they can get a sort of before the hospital type intervention to perhaps keep them in the community and better cared for. So there are a few ideas working on that, but it's a challenge. It's a major challenge.
Dr. Jones, you want to say anything on this?
Well, I think that we need to better understand the context in which the patient lives. And what we heard on Monday was a lot about understanding the broader, the family, the whānau that social situation in which the person is, and work with a larger group of people that can provide support for that person and help them towards a better understanding of their condition and how to manage it. I think that just providing more services in the community is just going to, you're just shifting the place, but not actually the amount of input.
Deborah, any thoughts on this?
Oh, it's an interesting term, frequent flyer, isn't it? I think if someone is presenting to hospital regularly, have we failed them in some way? Have we let them down? Are we not noticing what's really going on in their life? Are we missing something? I think we need to look a bit deeper than that.
Yeah, I think the cultural and the cultural connection to those people, as I think was said. In the States, there's a new kind of professional entity called the community health worker, which is kind of the care coordinator person, but it's not someone who has that level of either nursing or social work training, who's trained at a relatively simplistic level to help people navigate their world. And they're out in the community, and they're doing the community touches. They're not particularly high paid or expensive as part of members of the team, but I think places where they're starting to engage them is really tremendously helpful. If people are not aware of that, one of the well-known thinkers, at least in the States, Atul Gawande, the surgeon, who writes in the magazine, The New Yorker, frequently, and he had a seminal article, might be almost 10 years ago now, called The Hot Spotters. And he focused on city Camden, New Jersey, right across the river from Philadelphia. And he focused on this guy who was the director of public health for the city, who was overwhelmed with costs of patients going to the frequent flyers. And he investigated them, and they basically took, like a community health worker, care coordinator, assigned them to those patients so that they were getting intensive, kind of one-on-one, somebody following them, and it cut down on the hospitalizations and the ER utilization absolutely dramatically. It's a fascinating concept, and now it's starting to roll out. So other questions. Is integrated care cheaper? Dr. Jones.
Well, quality care is cheaper. Because it's less wasteful and it's less harmful. And so I think if the agenda is a quality agenda, then it should be. But you'd have to put some investment in first.
Okay.
Yeah, I think that's the answer. Up front, it's cost. In 10 years, it's probably cheaper. It's hard to measure that. And of course, it's often the people who put the money up front don't reap in our system, they don't reap the savings in the future, if that makes sense. So it might be the state government puts an investment in now, and the Commonwealth government reaps the saving in the future.
So the next question, so we're starting, just a few more minutes. So I mentioned before, how do we incentivize practices to be medical homes? We talked about the concept of the medical home neighbor. So I guess the question here is how, if we're going to have truly integrated information tools, how do we ensure that specialists engage? I would venture to say it might be having specialists become more interested in becoming medical home neighbors as that construct is applied. So how do we incentivize specialist practices to truly take on that structure and that communication willingness that being a medical home neighbor involves?
Very challenging. General practice in Australia computerised over a period of about 3 years in the late 90s. Went from rates of something like 20% of GPs having a computer on the desk to 97-8% having over about a period of 3 years. What was done was local support, funding incentives, and some system changes, and it was very effective. Those are the sorts of things that can work. Certainly the biggest gap that we find in the Nepean Blue Mountains at the moment is private specialist rooms in terms of engagement, because I don't think the value proposition is there. It's not a criticism, actually. It's just that at the moment, there isn't a value proposition which is causing those practices to transform. I do think there's a problem with shared vision. We don't necessarily have a shared vision of what we think the health system is and what our role is in it.
The specialists and the GP?
Everyone in the system knowing we're headed towards this. And talking with people at integrated care conferences, they reckon it takes about 10 years of pounding away at it. This is our vision, this is our vision, this is our vision, before it finally starts to permeate the whole system and everyone buys in.
Okay. Any thoughts?
The approach that we're taking with our framework that I've discussed is that you can't. force people to do anything. So what we do is we work with the willing, and there are some very passionate people who want to get on with this, and that's where you start. And so the ambition is to create a social movement actually for quality improvement. And that's the first one. The second one is to give them data, because clinicians love data, number one, and two, they're competitive. So if you can show them that their health outcomes are different from a neighboring district, they will tend to actually start to engage and look at what's happening. And that's quite a key way of doing it.
I'd agree with that.
Okay, well, we move on to the last couple questions. So would patients gathering their own data, back to that, but also learning how to manage the condition using the data, would that keep the balance between self-care and clinical care? I'd venture to answer that yes. I guess the question I would say is, so how do we get patients to actually learn how to manage their data? Deborah, any thoughts?
I have no idea. I'm going to leave that up to you. You're all the experts here. I think we need to get patients to understand more the importance of data, because patients can become very frightened of where their data goes.
I'll answer that a little bit. I guess I've been in a medical practice situation where I had a number of other general internists and specialists, and we had a clinical certified diabetes educator who's an RN trained, and then she did extra training in diabetes education. And it's so that the education of the patients is not necessarily the responsibility, back to team-based care, of the clinician or of the physician or APRN or PA. It's other people on the team, and whether it's a certified diabetes educator, nutritionist, someone like that can spend much more time and be a better educator on a lot of those aspects than a clinician. That's what they do, and they do it well. And I think that in all of these areas, there are probably certain members of the team who, whether it's part of their training or who can become well-trained in being good patient educators, so that the patients do, in fact, become much more empowered with the data. But it's not easy, and it takes time and relationships and all that kind of stuff, which you need to have as part of a medical home type team.
Yeah, the chronic care model, a very prominent model that's been promoted for 15 years, and the aspect for which there's best evidence is patient self-management. That's one of the things where there's most evidence is of effectiveness in the chronic care model. And certainly talking with patients about numbers and people getting the idea of what their goals are, I've certainly found on an anecdotal level very effective for when they know they're headed for a particular HbA1c. They'll ask you, what is it? How are we going? And I think people then start to drive towards it. So I find data very helpful.
So kind of related to that, I think I'm going to skip the top one. I think we've kind of touched on a little bit, trying to engage specialists. At what point does the data start to merge into areas of kind of unwanted surveillance from the patient perspective? You know, when you're asking for lots of information, or potentially systems are collecting information, in registries. This is an issue in the States now where people are increasingly concerned that data is being pulled. They say anonymously, they may or may not believe that. And kind of a big brother is watching over a lot of this. Theoretically, they shouldn't become uninsurable or those kind of issues that we have, but they worry about that. So how do we reassure patients that the systems that we're trying to create are for their benefit and not to control them?
I think consumers need to be educated or reassured of why we're collecting the data, and to understand that the data is necessary for us to plan and deliver the healthcare services that is needed in a particular area, and why that's the case, getting back to the why question. If they don't understand the process of why we're doing something, they're not going to trust it. Oh, you don't trust it.
In Australia, we've just been through an incredibly robust debate over our national online health record. Yeah. It was about to go to everybody. It was opt-on, became opt-off. That meant you would get one if you didn't opt off. And they postponed it for 3 months because they raised a number of issues with this very thing. How can we be assured that our data is safe, that you won't use it inappropriately? And in fact, they brought in extra protections. Previously, you could not, once you got on, you could not delete it. You could make it inactive, but you couldn't delete it. They changed the rules. You can now delete it completely if you wish. So I think that was really good. I think there were some problems, and they went to the point of empowering people to say, all right, fair enough. Do you have that concern? We'll give you the power that if you're not happy, complete deletion. And we have gone forward. Still, 10% of people said we don't want to opt. We will not opt. We will not allow ourselves to have a record created, which I think 90% is actually pretty good.
Yeah, I do too.
Yeah, the opt-in, opt-out is a big issue that we've dealt with in the United States as well, more at state levels, but big issue. So kind of related to that, so I think the sharing of communication among clinicians, inpatient, outpatient, getting to the kind of the last question is big. If in fact the outpatient doctors don't know what's going on in the hospital, there's confusion, there's uncertainties, and vice versa. So I guess if you have a unified health record that everyone sees, that's inpatient, outpatient, that's easier. Should we have more specific interactions between the GP clinics and specialists or in the hospital? Any thoughts on crossing the chasm of outpatient versus inpatient worlds from an integrated care standpoint? I'm going to put Dr. Jones on the spot.
Well, I think that's just unfeasible. I mean, we've got very resource constrained services, and I just think people don't have the time to, GP, can you imagine? A lot of GPs went into general practice because they hated going on ward rounds with consultants. So I think you'd need to find different ways than actually doubling up and having both necessarily in the same room. And that's often the problem with doing virtual outreach clinic, is that no GP wants to be sitting with the patient and a camera and the specialist 200 kilometers away, doing something else. That is often an activity that happens with nurses. So I just think we need to find different ways of improving those relationships and interactions.
I agree. We haven't nailed the way we work together, and there's huge opportunity, I think, with new technology. I remember hearing a guy called Doug Eby from Nootka in Alaska. That's a patient-owned health system, an indigenous health system. He says consultation time shouldn't be in 2 weeks, it should be in 2 minutes. You should be able to get a cardiologist on the line in 2 minutes to have a discussion about patient management. And they seem to manage it through some very interesting systems. I'm not sure how practical that is, but I do think interacting more as more part of a team somehow. I'd be interested to know how you do it in terms of the support you offer from the rheumatology clinic. I know you're very resource constrained, but that sort of support that you offer GPs, I think that's going to be very effective and timely and cost saving.
Well, I think you just need to make better use of the telephone. Out of all this new technology, I actually find the telephone's one of the best.
Sure.
It's remarkable how infrequently we now pick up the phone and speak to each other. Deborah, any comments on that?
Oh, I'd just like to say, in closing, perhaps that in WA we've just had the Sustainable Health Review that was carried out by Professor Hugo Massey-Taylor. And one of the recommendations that came out of that was that for a sustainable health system going forward into the future, we need to implement models of care in the community for groups of people with complex conditions who are frequent presenters to hospital. So I think the RACP Integrated Care Committee is working on that very point, and it was very timely for this to come out, which filled my heart with hope that things can work together in the future.
Well, wonderful words to close on. Thank you very much. I want to thank Ms. Letica, Dr. Knight, Dr. Jones. Thank everyone for hanging around late in the afternoon. We didn't solve problems, but hopefully we gave you some thought-provoking issues around coordinated and integrated care. So thank you very much.